Hello, I want to thank you so much for joining me today. If you have any questions, please feel free to submit them. I'll try to answer them to the best of my ability during the Q&A portion. I'm Morgan Reyes, and this is a comparative approach to the treatment options for median arcuate ligament syndrome. First, I'd like to start out by briefly introducing myself. I'm 19 years old and I'm a freshman at Orange Coast College. Like many teenagers, I have lots of dreams and ambitions, and I try to do the best that I can in anything that I do. But that can sometimes be difficult given that I live my life with a chronic illness. Since around the age of 12, I've been dealing with a plethora of mystery illnesses that have brought me in and out of the hospital on multiple occasions. I've had many specialists, and no one has seemed to have an answer. But I recently found out that I have median arcuate ligament syndrome. And you might be wondering, what is median arcuate ligament syndrome? And yes, before you say anything, I agree that it has a really long name. So for the purpose of brevity, we're going to refer to it as MELS for the rest of this presentation. Here's a lower cross-section view of the diaphragm. We can see here's the aorta descending out of the diaphragm, and this ligament that wraps around it is the median arcuate ligament. If we take a look here, we can see that in a normal person's anatomy, the median arcuate ligament has a distance between the base of the celiac artery. If we look in MELS anatomy, we see that this ligament actually presses against the celiac artery. Here, if we take a look at MELS anatomy from a side view, we can actually see that there is bending of the celiac artery. This is similar to a bending of a hose. Now, instead of not being able to get water to your flowers, imagine that you're having restricted blood flow to your liver, spleen, pancreas, gallbladder, stomach, lower esophagus, and duodenum. If we take a look here, we can actually see that upon breathing out, a patient's symptoms can get worse, especially if we look over here where we see that the velocity of the blood flow has decreased significantly. Now you may be wondering, is there a solution for MELS? Well, that brings me to my next slide. Here we'll talk about laparoscopic surgery. With this approach, several small incisions are made into the patient's abdomen. A camera and surgical devices are inserted. The surgeon then focuses primarily on cutting away the fibers that are restricting the celiac artery. With this approach, most individuals find immediate relief, with a small percentage reporting recurring symptoms after surgery. But is restricted blood flow the only cause of pain in MELS? I mean, if we take a look at a research paper that was published in 2001, we can see that an estimated 7.3% of all people have some sort of compression of the celiac artery. Now this makes you think, why aren't there more people reporting symptoms? This is where a secondary treatment option comes into play. Many physicians are now theorizing that one of the main sources of pain in MELS patients is actually the neurological effects associated with the compressed nerves at the base of the celiac artery. If we take a look over here, we can see the aorta and the protruding celiac artery. Additionally, we see these yellow structures, which represent nerves. These two bundles that sit above the celiac artery are actually celiac ganglia. If we notice their position and we think about how in median arcuate ligament syndrome, the ligament actually presses against the base of the celiac artery, we know that these ganglia are going to be compressed as well. Now, in a modern open surgery, a surgeon not only focuses on relieving the pressure caused by the median arcuate ligament fibers, but they also cut away the damaged or inflamed celiac ganglia. Now, there isn't a whole lot of published data to support the fact that this surgery is superior to the laparoscopic surgery, but there is one hospital in Connecticut, Sanford Hospital to be specific, that boasts a 90% success rate among their hundreds of patients, therefore giving it some sort of efficacy. If we take a look over here, we can see a closer view of the celiac ganglia in relationship to where they lie with the celiac artery. We can also see this large scar caused from the open surgery. Patients who underwent this surgery described a recovery period between 12 and 18 months. This is significantly longer than those who underwent the laparoscopic surgery. You may be wondering why a patient would want to get this larger scar and undergo a larger recovery period in order to get this open surgery. This is because the leading mouth surgeon in the nation utilizes this surgical method and has stunning results. He has many patients who have undergone laparoscopic surgery previously and see him to resolve any remaining symptoms that they may feel related to mouths. Because there is such limited data directly comparing the results of open and laparoscopic surgeries, I felt as though I had to create a patient survey to find out for myself what was actually going on. It consisted of 17 questions and was supported on 2 separate mouth support group sites. It received 42 responses and consisted of both Mal's patients and Mal's parents or caregivers. Here we can see that the demographics of this survey actually directly correlate with previously published data. A majority of patients were female. There are patients in all age categories, and 100% of them identified themselves as Caucasian. I started the survey by asking patients what some of their symptoms were. As we can see, these are some of the most reoccurring symptoms that appeared among the survey. And while many of these are debilitating and hard to handle on their own, I also chose to include comments, specifically ones that I felt reflected the true nature of mouths. We can see passing out from pain after eating, radiating pain and difficulty breathing, pressure in chest, always felt like having heart attacks, at times felt like 20 cinder blocks sitting on me, pressure on chest like something heavy is on me, fatigued, exalted easily, racing heart, sweats, brain fog, headaches, lots of GI issues, extreme fatigues, difficulty getting full breath, causing panic attacks. These symptoms are debilitating and take away from a person's quality of life. If we look here, we can see the pain of these individuals at the time of their diagnosis. We see that 83.4% of these people reported pain between 7 and 10 on a pain scale. We also see that 16.6% reported pain levels between a 4 and a 6. No one reported pain levels less than a 4. The data also showed us that the median pain level was a 9. This lies somewhere here on the pain scale, and for most people is worthy of taking a visit to the emergency room. I then asked patients what their pain level was like before and after treatment. The open surgery had a sample size of 23. We can see that a majority of these patients experienced pain levels between 8 and a 10 before treatment. However, after treatment, these pain levels dropped between a 0 and a 5. This creates a nice valley shape that we can see similarly with the laparoscopic surgery. Now, since my sample size was so much smaller for the laparoscopic surgery, we don't see an exact reflection of this open surgery graph. Additionally, in the survey, knowing my own experiences and struggles to get a diagnosis, I asked others what they felt the medical community's understanding of mouths was. And as you can see, a majority of people felt as though knowledge was lacking. In fact, when I asked patients the amount of time that it took for them to get a diagnosis for mouths, only 3 people in the entire survey reported fewer than 6 months to get a diagnosis. 36 reported more than a year, and 15 reported more than 5 years. If I had taken the survey, I would have belonged in this group. If we take a moment to think back at the median pain level that was found among patients at the time of diagnosis, we can remember that it was a 9. Imagine living with a consistent median pain level of around a 9 for over 5 years of your life. It's debilitating and frustrating. I know that from personal experience. And honestly, I wasn't expecting to see the same thing among all of these patients. But this reaffirms that there is a trend that needs to be fixed. While this project was initially intended to identify which surgical option was best for mouse patients, we can see that there's actually something much more urgent that needs to be addressed. In order to solve this issue of lack of knowledge among the medical community and patients suffering for so many years with an unidentified illness, I've created a short list of recommendations that I think could greatly impact the quality of life of those with MALS. First, we have to start out by educating medical personnel. If doctors don't know what's going on, then how will patients ever know? Second, when a patient gets diagnosed, we need to collect data and publish the results of their treatment. This is the only way we can actually find the answer to which surgery is the best option for MALS patients. And third, we need to consolidate information for patients with MALS. That way they can make their own informed decisions on which surgeries are best for them until data has been published to support one or the other. After doing this presentation, I feel it is my responsibility to do my part to contribute to the recommendations I've put forth. I will continue to interview patients with MALS and record their stories so that other patients, like me, who are going through a new diagnosis can have the support that they need and an understanding of the process that gives them a stronger view on what is to come. Thank you to everyone who helped with this project and to everyone who's watching. You've not only helped me, but you're helping others with median arcuate ligament syndrome.